Hi, everyone. This is Dr. Angela Lin, the co-director of the MGH Myhre Syndrome Clinic, and I'd like to talk to you a little bit about our clinic. I'm going to turn off my video and go right to the slides. The title of the talk is the MGH Myhre Syndrome Clinic from 2014, 2022, 44 personally evaluated patients. And behind the scenes is Eleanor Simone, our wonderful clinical research assistant, who's being promoted to clinical research coordinator. Some disclosures in that I do volunteer for the Professional Advisory Board. I'm on the editorial board of the American Journal of Medical Genetics, and I do work as a consultant for the Department of Public Health. So this is another type of map I created. I wanted to make some suggestions about how to view this talk. You can listen to it now. I'm a fast talker, and you'll need to go back and look at it again. But this is complemented or supplemented by other talks that I've given. One from last year about how do we do guidelines, the excellent talk about genetics by Dr. Starr. This year I have a little talk about how to coordinate your team, and there are many other talks by all the other specialists. So they all fit together. And then maybe sometime the end of the summer or the fall, just go over this one more time. So part one is about 10 minutes. I'm going to talk to you about the structure and staff of our clinic. Part two, we'll look at the defects, the functional problems, compare the different SMAD4 variants, and you'll hear different talks about all these specific organ systems and situations. So we are a multi-specialty clinic. We see children and adults, 44, and they range in age from 1 to 50. So it's quite the lifespan. And this is the photo directory of our different wonderful specialists who cover adult medicine, pediatric medicine, and we have, partnering with different parents too. So to learn more about the clinic, you can search on the Myhre MGH Clinic. Just put it into the search bar, and you'll see pictures of some of our patients. You'll have access for free to some of our handouts, some of which we're trying to translate into different languages. We have a lot of materials that we give you if you do come to visit us. And the way I report patients is in a standardized form it begins with who is following the person, the history, the examination, and it concludes with a very systematic review of each organ system. Hopefully that will help you, everybody. I take a lot of pictures, ask patients to submit them to me too before I see them, so I have an idea what your child or you look like. And we have little images that guide the discussion at the end. So we are the only clinic of its kind, certainly in the country. I can't speak for Europe, but there are plenty of people around the world who have expertise. Certainly my colleagues in Paris, Naples, Belgium, Norway as well, around the country. And even though there may not be other Myhre syndrome clinics, there are cardiogenetic clinics in different places, in Canada, in Europe, and Australia and Asia. So each of these represents a place where somebody has contacted me or where I know they're following a patient now. And I like to think of care as a series of linked circles. At the center is the primary care doctor, PCP. Genetics plays a big role. Then we have cardiology, pulmonology, physical therapy. I often call this the core of four, but we certainly have a lot of input from ENT and what I call the brain health specialists, neuropsychology, therapies, and psychiatry, and many other specialties for many other different problems. And then my role is to sort of help navigate the ship, keep everybody together, communicating. I do this with our in-house electronic medical records called EPIC, as well as Care Everywhere, and I try to pull it together into your team. And this is what I speak about in the complimentary talk. You or your child have Myhre syndrome, now what? And the way we think about care is we think of it across the lifespan, different issues at different ages. So these are sort of the core: diagnosis, the genetic part, heart, airway, breathing, ears, growth, behavior, development. And then as somebody gets older, we add in different issues all the way up until the senior years. One question we're always asked is, how do you pronounce this name? So the Norwegians pronounce it Myhre or Myhre. In the UK, I understand people say Myra. We in the United States, we pronounce it the way Dr. Selma Myhre pronounced it. She lived in Washington State, so we'll call it Myhre. There's some genetic terms that are present, are illustrated in Myhre syndrome. Genetic homogeneity. You've got recurrent variants or mutations, but only in SMAD4. This is the only gene. Phenotypic heterogeneity. There is a spectrum of severity. People are affected differently. Pleiotropy, a fancy word that means almost all organ systems are involved, but not all patients have every feature. And natural history means that we follow people as they get older into adulthood. How common is it? It's hard to know. We can say that in the literature there are at least 100 patients, and this increases daily, but they're usually small reports or case reports. As a rare syndrome, we have to be careful of duplicate reporting. Some patients have been reported more than once, and we really at this stage need to see that everybody has been validated with a molecular test. In Massachusetts, we have 6 people, so it's about 1 out of 1 million. In the United States, it's also roughly about 1 out of 1 million. These are very informal calculations that I've made. I did contact one of the major labs who tell me they've seen or they've diagnosed 33 cases, and that was reassuring to me. That's about what I would have expected. Worldwide, we don't have an international estimate. And I know that the Facebook families and the registry, they keep track of people. But again, that doesn't allow us to calculate a prevalence. You need a denominator for that. So some of us went to a fancy database called Nomad, and we did find 3 variants there. You don't know much about the people. These are anonymous, but it's hard to calculate, again, a population frequency. So as a best guess, I'm going to say 1 out of 1 million. So to determine how we come up with criteria, how do we diagnose somebody clinically? You go back to the first report by Dr. Myhre, 1981, 2 individuals, 2 males, who were fairly severely affected. And I don't think they reflect uh, the people that I know. And over time, people reported people who had milder appearances, close to normal intelligence. And then the 2 groups that describe the gene, Legoff and Caputo and all of their colleagues, they, recorded these clinical features, and I think that we still view them as correct. When Dr. Starr and I wrote the gene reviews in 2017, we modified this list and we actually did try to test it. We tried to see if we could come up with minimum criteria, did not complete that research. And so we're continuing to look at this. And I had given a talk last year called How Will We Get to These Evidence-Based Guidelines? And we are getting there very quickly, actually. So to review the genetics, I'm going to refer you to Dr. Starr. I'm not going to go through all the different variants, which I think is really important. I'm going to review, the clinical, the features, and I'm thinking that clinical care makes us want to find solutions. And we will ask you what you think is important, listen, and try to do this. And the way we do this, the way we get to solutions, is through research. So again, this is an overview. Details will follow in an article eventually. As we look at the information that we use to evaluate this syndrome, we have to look at the quality of the data. I'd like to think that our MGH evaluations are at the highest level. There are outside tests and consults. We look at actual images, MRI, CT. Telemedicine is so useful, but it is not the same as meeting me in person. That's really important. So eventually I need to see everybody. We have parents and people reporting features, which are really important. We also like to validate that. Lack of follow-up is an issue because people change, our opinions change, and the plans change too. And there can be incomplete testing when somebody is young or has autism. We can look at some basic data and do what's called multivariable analyses, statistical comparisons. Haven't done them for this talk though. And so there is a cycle of clinical description. Your visit to our clinic is what we call deep phenotyping. We try to answer who has what, when, and where. And the other stage is when we really start to generate hypotheses in humans and animals about the pathophysiology, what's going on, what's causing it, why is this happening, and how. And finally, the gold standard, the holy grail would be actually coming up with therapies that are based on the pathophysiology. In the meantime, we use symptomatic treatment. Non-intervention is sometimes a treatment, and we try to translate from the genetic defect in the future, and we will do trials eventually, we hope so. So now we're going to really get into some of the data. I'm going to start with probably the most important thing, which is how many patients have the SMAD4 arginine 496 cysteine, I'm saying it in a very short way, variant, in contrast to the other variant, which we sometimes called isoleucine at position 500. And the split is about 60-40. This is shifting a little bit. We're seeing more of the arginine. Among those who have the isoleucine position 500 variant, this isoleucine amino acid can change to valine in about 50%, and then the others are quite rare. Threonine, a change to methionine, and a change to leucine. Okay? So that's why most of the comparisons will be made to this main isoleucine position 500 changing to valine. So we have about half of our patients are self-referrals. Others come from, doctors, and then we do have some that come from outside the United States. So the age at diagnosis, we are comparing those who are young, less than 2, and those who are older than 18. So we've seen about 18% each, and it looks like maybe there are more that are found to have this particular variant. However, what you have to do is you have to compare not only this comparison, but how common is this in general? And remember, I said that the split is about 60-40. So when you have a comparison of 75 to 25, it looks like it might be meaningful, but we'll have to check. And it's similar also for the older patients. So what I think we're saying is maybe we're seeing more people at the ends of the spectrum. Our patients are white, multi-ethnic. We have not seen any who are Black. We have more females, slightly more females. And again, if you compare the SMAD4 and the arginine, it looks like they're pretty balanced. I'm trying to find things that we will be able to test to prove that they are really different. And what about this down here? Are there more males, proportionally more males with the isoleucine 500 variant? And there might be. And we look forward to testing that. So this is going to be a theme. I'm going to show you data and then I'll comment on whether we think it's meaningful comparing the two. What about the genetics? So whole exome sequencing is clearly the most common type of a test. And then we see people who've been diagnosed by intellectual disability autism panels, hearing loss, even cancer panels, and some people are diagnosed by a targeted gene approach. And that's when there's more certainty about the diagnosis. We see other genetic issues such as infertility. And what I have in parentheses here with an asterisk is sort of the population frequency. So it's actually kind of similar, 18% versus 50%. What about advanced paternal age, which is older than 40? So the general population is about 30%, and we are seeing it in maybe 13%, so maybe not that much. But the advanced paternal age might be a little bit older. So we see this in 31, and in Myhre syndrome, it's more like 46. So we might be seeing a little bit more. Advanced maternal age, maternal age is probably not present. So what about this advanced paternal age? Because I've talked about it before in person too. So we see this in certain types of conditions. They're called single gene disorders. And here's a list of them. So the fact that Myhre syndrome might show that is not really a shame, really a surprise. But having increased risk is not the same as causing it. Another genetic issue is what we call variants. So when we do some of these genetic tests, we pick up other changes, and we have to wonder, are they meaningful, non-pathogenic, or do they represent a second disorder? Are they unspecified? Some of this I know is technical for many of you, but I'm just presenting it for the general audience. And so in fact, we do see some people who've had a second diagnosis. Here is somebody who has Myhre syndrome and ichthyosis. And what about twins? So in the general population, the frequency of fraternal twins is about 1%. In our series, it's more like 11%. Let's turn to the heart, which is certainly an important organ. And so what we see is we see some type of a cardiovascular abnormality in 60%, okay? And about a third of them have a congenital heart defect. It can be an ASD, a VSD. The PDAs, which are actually common defects, are actually usually different because they're large. And sorry, I moved too quickly. Pericardial effusion, which can be a concern, is about 9%. And restrictive cardiomyopathy, which is rare, it's about 5%. And really, the way to sort of get a handle on the cardiovascular problems is to listen to Dr. Lindsay's talk. I know he gave one last year. I'm not sure if he's revising it for this year. Some more hard things. Let's talk about the aorta. And coarctation, which is a narrowing of the aorta, can be seen in about 7%. And it can be a challenge. It can be more than the typical, what's called juxtaductal, and more a long segment. And there can be recoarctation. We feel that the aorta is sort of a target organ in Myhre syndrome. And hypoplasia narrowing is seen in most of the patients. We've seen it in all the patients with the arginine, most of the patients with the isoleucine variant. And so it is common, but it does need a lot of care looking at it. In a minority, though, it is moderate or severe. And all of our patients have had an echo at least once. Some people have had more than one. We like to do a more sophisticated imaging of the aorta called the CTA. Some people do an MRA. We wait until the child is about 6 or 7, able to have this done. The coarctation does require surgery, as do some of the other heart defects. Hypertension, high blood pressure is seen in about 57%. And it is treated with a variety of different drugs. Those of you in the audience can recognize things that you are taking or your child. The most common category is called angiotensin receptor blockers, and losartan is the most common. And these are different types of drugs. At least 9 patients were on 2 or more. So other arteries can be involved, not just the main aorta. We can see renal arteries having narrowing at about 10%. And the coronary arteries can show some minor but real problems. In at least one patient, there was actually severe stenosis of some of the vessels. So that's something we're watching. When we talk about the heart and Myhre syndrome, we're comparing it to other syndromes, Down, Noonan, Williams syndrome, Marfan, DeGeorge, which have distinctive or fairly distinctive patterns. And so Myhre syndrome is now added to this group of disorders. So we see this left-sided obstruction, mild shunts, rarely tetralogy, segmental narrowing, coarctation, which is uncommon, but more common is the diffuse mild to moderate hypoplasia, and pericardial disease, which is uncommon, restrictive cardiomyopathy. So what we're talking about is a pattern. What about the airway and the lungs? So Dr. Kanan gave a great talk last year, and he's updating it for this year. Here's some of the data just presented very simply. About a third of our patients have had stridor or croup. Airway narrowing, which does concern people, is rare. In one patient, it was multiple levels. The choana, or is above the nose, tracheal bronchial stenosis. And what we see is that it can progress. And I know that is concerning to people. Abnormal sleep, common. Having a sleep study performed, we think is important. Treating the sleep, Dr. Kanal will talk about that in his talk, okay? And what about lung problems? We're fortunate that most of our patients have been seen by our pulmonologists, adult and pediatric, and other patients elsewhere have been evaluated too. So a lot of patients will have frequent respiratory infections. Some will have what seems to be asthma. Again, I'm going to let Dr. Kanan talk about that in his own talk. And pulmonary function tests, which are breathing tests, are really important. You can't do it in everybody. It's not always available. Young children, some of the children with autism are not cooperative, but it is useful in helping to interpret the clinical problems. And we do see a restrictive chest wall. And this is, helped with diagnosis by the pulmonary function test. Let's talk a little bit about the face. Now, what about the facial appearance? I would say all except one person that I know has some type of facial features. And of course, I can see things that may be extremely mild. We see a problem with the palate. It can be clefted. There can be what we call velopharyngeal insufficiency. There can be a prominent jaw, and there can be restrictive mouth opening. Teeth are usually small or wide spaced. What about ear? So we think about the shape of the ear, hearing problems, ear infections. Dr. Cohen did a great talk last year. And here is a little bit of data. Having frequent ear infections occurs in at least half, maybe more. Getting ear tubes in about half. Having lots of earwax, we call cerumen, is common. Hearing loss occurs in about half. Okay, it usually is conductive. It can occur because there is a structural problem. And I think we're going to see that this is a little bit more common as we do more tests. So it does occur in probably over half. What about hearing aids? There can be traditional hearing aids, the Baha, and cochlear implant in at least one person. And this is changing with time. And an inner ear anomaly means that there's a structural problem for the hearing loss. What about eyes and vision? The most common type of visual problem is hyperopia, not nearsighted but farsighted, with astigmatism. So about 40%. Strabismus, narrowing of the tear ducts, nasolacrimal duct stenosis. And you'll see some wonderful details in the talk by Dr. Gina Hadari, who is the ophthalmologist. She's based at Children's. She sees our patients. There are a lot of minor miscellaneous things that she will go over too. Now let's talk about the imaging of the brain and the spine. And I'm going to highlight the project that's being directed by Eleanor Simone. This is really her great interest. And we've done a lot of work, and we thank all of you who contributed to it. So one of the simplest things about the brain is to say, how big is the head? And most people have a large head size, macrocephaly. About half have a sacral dimple, and we get a spinal cord MRI in about a third. Some of the children, some of the people have a problem called a tethered cord, and the operation is called detethering. We need more information about the outcome to judge its success. Neuropsychology refers to how a person learns. And we will start by telling you that I recommend neuropsychologic testing in everybody. I think there are enough differences in Myhre syndrome that is really worthwhile to get formal testing. So about 60% of our patients have been tested, 30% at MGH, elsewhere that's been done. Developmental delay occurs really in everybody, but it can be very, very mild. And intellectual disability in about half, the IQ is less than 70 in about a third, and borderline in 11%. ADHD is documented in 55%, probably more common. We haven't formally tested in everybody. And autism or having social challenges, ASD, most of the patients, most people, about 84%. What about psychiatric problems, which is different from neuropsychologic? Now, if you exclude ADHD, we would say that we do see this in 20%, in round numbers, depression, anxiety, outbursts. We have not seen psychosis, but it has been reported by other people. Medications are commonly used, and this is a large group, and I'm not going to say each one of them. We divide them into the treatment for ADHD, which includes stimulants, mood disorders, sleep. And, medication is a part of treatment. It doesn't mean that it's not meant to stigmatize anybody. It's a useful part of our treatment. So what about hormones? And this comes under the specialty of endocrinology. So growth, puberty, or metabolism. And what we have seen is that we might see a little bit of a difference. So babies who are small, SGA or IUGR, we see it in about 60%, but it seems to be more common in those who have the isoleucine variant, less common in those who have arginine. In fact, if I'm told that somebody has normal stature, I generally think that it's probably an arginine. It's not possible. It's not impossible, but this is usually the situation. And then after birth, short stature, the same thing, that it seems to be less common in those who have the arginine variant, and more common in those who have the isoleucine variant. Growth hormone has only been used in 5 patients, 11%, and those are by outside providers. We do not endorse it. So what about premature puberty? You may have heard about this. We're just starting to get a handle on it because we're starting to pay more attention. And in males, it does occur. It might be a little more common in females. We see this, We have observed diabetes in at least 3 people, 7%, and it can be quite severe. So that's why we're very attentive to people monitoring their diet. We think this is related to Myhre syndrome. Overweight is common. We see it in at least 75% of our adults. Talk a little bit about gynecology. So this refers to the females, 25 rather than the whole data set of 44. So 4 of our patients have been evaluated by a gynecologist. We see macromastia, large breast, in girls who are older than 12 in about 25%. Many girls and women report prolonged, painful periods. I don't have sufficient reliable data to give you a figure, but it definitely does occur. And medications can be used to control this. Sometimes it's a birth control pill, an implanted device, an IUD, and this is the way that hormones can help manage these severe periods. A hysterectomy has actually been done in 2 women. Pregnancy has actually been undertaken by a person who did not know they had Myhre syndrome. It was not successful. So GI is certainly a big issue. We can see intestinal obstruction. There's something called pyloric stenosis and duodenal atresia. And what is quite striking to me is that in at least one person, the obstruction occurred later in life. It was somebody who was actually a young teen. And that shows this proliferation, this concern about Myhre syndrome. Reflux in about 25%, requiring a G tube to help with feeding. Overeating is a bigger problem. Liver dysfunction, something called protein losing enteropathy, and gallbladder has to be watched. But the most common thing is, of course, constipation. The 59%, I wonder if that's an underestimate. Sometimes it's so severe that people can have overflow encopresis, and it often persists despite a vigorous clean out. I know this anecdotally, I don't have the actual numbers, but often people say, Dr. Lynn, we've tried everything. There is a way of assessing this by something called anal manometry. We've used it once. And sometimes we actually need to do a colonoscopy or endoscopy or take a little biopsy to find out, what's happening down there with the intestines. What about musculoskeletal? So stiff joints and stiff gaits are very common, aren't they? At least 77%. Frank arthritis and contractures is something that we're concerned about. We've seen it in at least 16%. And this is related to this proliferative process that we see in Myhre syndrome. There can be short fingers, curvy fifth fingers, clinodactyly, trigger finger, brachydactyly, meaning short toes, short fingers. Syndactyly is shown as pictures. When the second and third toes are fused together, overlapping toes can be a problem too. Scoliosis, about 14%. Fractures seem to be more common. We see that in 16%. I think that's more common than the general population. And there can be reduced supination, pronation. That has to do with the ability to rotate the lower arm. A complete skeletal survey has been done in 23%, and I feel that it's something we need to do more often to start looking for some of the meaningful problems, which would be scoliosis, fractures, as well as the arthritis. The skin is often involved, as you know well. At least 70% have firm skin, thickened skin. Not everybody, though. And there can be a fine, bumpy rash called hyperkeratosis pilaris in 43%. Scars are very common, aren't they? There can be a hypertrophic scar called a keloid. There can be just unusual scars that just persist, 25%. And at least one person had really difficulty post-operatively with wound healing. The skin can be a little bit darker. We can see birthmarks called cafe au lait spots. Let's turn to urology and nephrology. Urology refers to the external genitalia in the male. Nephrology refers to the kidney. And there is at least one person who had hypospadias. Renal anomalies, meaning congenital problems that people are born with. A small kidney, an absent kidney, a horseshoe kidney are rare. We are observing one person who has renal scarring, and somebody who has what's called, a couple of people have a hypotonic bladder. You'll hear a talk by Dr. Wei Tan, which will really expand on this. What about appearance? People are always curious about the appearance in people with Myhre syndrome. And we do know that it varies by race, ethnic group, mood, glasses, hair, setting, pose. So these are natural features. These are external ones. So getting a good picture really helps, I think. It depends on what the rest of the family looks like. Depends on the age. Young children look strikingly similar. It's really incredible. Parents will say that as well as providers. And this is a wonderful montage. I want to thank the mother who carefully assembled this for me. Here's her darling son. Here he is, maturing over age and his graduation. So we see the face changing with time. This is another wonderful montage. Thank you to the wonderful parents. And you can see the similarities in these children at the very young age. And changing is just very, very mild. This is thanks to April Lenord and Alec Bruneau and to the Lee family. So what about Myhre syndrome around the world? There are similarities and some differences too. This is from a paper from France, another from Italy, Turkey, Hong Kong, the Chinese, as well as Mexico. And at your leisure, you can go back over this slide and compare the different faces. And the question is, does it matter? Maybe. How a person looks might be a signal about the rest of the body. It might provide insight into prognosis. Maybe it predicts what other defects should be expected. We certainly don't have that information now. We need more people at different ages and different backgrounds. And last year I was given permission to show these faces, and some of the faces are shown clearly, others are blurred, others are represented just by a blue or a pink for male or female. And these are the people who have the arginine 496 variant. These are those who have the isoleucine valine variant. And these are separated out into some of the individual ones. And the dotted line refer to people who are multi-ethnic. We have a very diverse population. We have several people from South America who are Hispanic. We do not have any Black patients. But again, at your leisure, you can go over some of these faces. When I've shown this to people, geneticists, people feel we cannot tell the difference. I cannot say that one person is more likely to have this or this. So appearance was evaluated informally or unintentionally in an important paper by Bert Keiwert and Ilse Mershow. This is from Belgium. And it is a mother with two children. And this is important because it's a family. And it does represent maybe the change of the face over time. This is another man that they reported, but he's not the father. And we can update on this notion of familial SMAD for arginine 496. There are other cases in addition to the one reported. I know of another paper in the literature, and I know of another patient, another family that is in submission now. So this is happening. So how do we come up with a composite? A composite means that you take all the faces that you can find, and this is done by a company called Phase 2 DNA. This girl does not have Myhre syndrome, but this is the face that is available. And your doctor, especially your geneticist, can use it, and I think it is helpful. Most people have said, yes, they can see the face in this. So immunity will be discussed in detail by Dr. Stella Hartona and Pam Guerrero from the NIH. It's an update of the 2021 talk. And I, for one, am really excited to see what they have to say now. Cancer was discussed by me in my talk from last year. It remains a rare finding. In other words, we talked about 6 people, 3 of whom had the arginine 496 variant, who had the same cancer. These were women with endometrial cancer. I haven't found anybody who's told me that we were wrong, but we have not identified other cases. So I'm going to just quickly run through some of your questions. Should a blood panel standard test be performed periodically annually? We don't have formal, rigorous evidence to recommend this, but practically we say, yes, we should start doing this. So at diagnosis, we're recommending quantitative immunoglobulins. When people are 12 to 13, check for diabetes and a lipid panel. But really, those are the only Myhre-specific ones. What about screening for neoplasia? You have to go to my talk to listen to me describe this more. At present time, there is no specific imaging or blood testing. We want people to be aware of it. Those people who have, those women who have the 496 variant, who have early onset of menstruation, we would watch them the most closely. What about the role of music to maximize brain development? No evidence to suggest that it helps Myhre syndrome in particular, but children with intellectual disability, autism spectrum in general, they love music. And so this is wonderful. I have seen many people really enjoy performing, not just listening to music. And it's promoted for the simple enjoyment to enhance behavior too. Next question, what should be expected in an infant with Myhre syndrome who appears to have few problems? And that's quite true. Aside from the few who have a severe heart problem, most of the ones that I meet in the less than 2 are adorable children. They are identified, though, for something. And that's the key thing. They're identified either because they're delayed, they're having features that might suggest autism, or they have hearing loss. So those are some of the problems. And, I can't predict the future, but we will say that developmental delays are seen in really everybody. And that just means to be attentive to it, to share it with your teachers, people who know the child. Autism spectrum is involved in most. It can be very, very mild. And I know some parents don't feel it's present in their children, but we've seen it emerge over time. And sometimes what happens, and here's something very positive, some people can have autism when they're young, but it can improve when they're older. And we do look for changes in the joints, from just stiff joints to more severe stiffness and even arthritis and contracture. So stay active, use PT. Heart problems can occur even if the first echo is normal, and so we just need to keep an eye on that. Do you expect the number of people with Myhre syndrome to increase? Absolutely. We're already seeing it at both ends of the spectrum. Um, Newborn and adults who are older. And because the Myhre syndrome of the foundation, your support, new families will be able to learn more sooner. So to summarize, the original features are present in most people, but the spectrum is greater. Ongoing research is essential. I can't answer your questions unless I have some data to draw upon. Features can be both congenital developmental and postnatal and acquired. Many are progressive. New features and defects are still valuable. For example, we reported patients with tetralogy of Fallot, but research is needed to advance to larger series and collaborations. Developmental delays are ubiquitous, but cognitive ability, behavioral issues, autism, and speech, they can vary and they can improve with time. Many people with Myhre syndrome have said to me, I had more issues when I was younger. I was determined to improve and it's worked. And I congratulate them and they inspire me. So research from individual defects, I want people to stop to look at patterns. So what is congenital? What is acquired? When we think of the aorta, is there hypertension? Is the renal function okay? This proliferative response you've heard about, skin, joints, ears, airway, are we seeing them together? Sometimes it does seem that way. Premature puberty, early menopause, uterine hyperplasia leading to neoplasia. This might be a spectrum. This might be a process. We think about the spinal cord and the brain. We're thinking about the bowel and the bladder too. And we've presented this at different places. Surgery instrumentation and airway protection. We need to think about how we treat people, how we diagnose them. I've conducted many conferences. I've just volunteered to do this with people around the world. We've talked about arthritis, the spinal cord and brain, ENT, constipation, optic nerve abnormalities. Research next steps. First of all, thank you to the Myhre Syndrome Foundation for providing our group with a $100,000 grant that is going to focus on a mouse model to study the heart and blood vessels as well as the brain. So it's even expanding as I speak now. We'd like to see therapy advance from symptomatic to genetic based. Rare syndromes are more likely to use a small drug trial than a fancy what's called randomized control style. We have this great REDCap database. Thank you, Eleanor, to do more sophisticated analyses, genotype phenotype analysis, look at demographics, survey parental attitudes. And the international Myhre syndrome community, we collaborate. So there's a big study going on about adults. Many of you know about that. We collaborated to report the tetralogy of Fallot. And patient-based data, the Myhre Syndrome Foundation is useful. It'll tell us about attitudes, provide us what we call descriptive epidemiology. We have outside collaborations now at the NIH with Dr. Guerrero. We have the adults. We have collaborators at the Mayo Clinic. We're going to keep looking at prevalence, epidemiology, and genetics. And I think I've mentioned these before. All right. And tissue biobanking postmortem. It is very important, folks, for us as researchers to obtain tissue. The simplest tissue is blood. And there we have a study, we have a biorepository in which we will ask your permission. Skin can be obtained, other tissues. If you were to have surgery, the ideal goal would be to obtain some tissue to save it. And so finally, I come to the end of my talk, and I must acknowledge everybody. The Myhre Syndrome Foundations and their networks for making events like this and future research possible. Our Myhre Syndrome Professional Advisory Board, wonderful people around the world. We have Zoom calls every other month, and we have parents involved. It's just terrific. And then my own Myhre Syndrome team at MGH, Eleanor, somebody else named Greg. So Mark, Eleanor, and I meet every month to go over your issues and try to really work as a cohesive team. And I thank Fund Development because I do need to raise funds to pay for Eleanor's salary and other things that we do. And I thank all the donors who may be listening. Referring physicians, so many, I'm grateful to. Thank you, everybody.